Hello, everyone. Thank you for joining us today. My name is Cynthia Klein, and on behalf of the entire Take Heart initiative, I'd like to welcome you to today's session. We hope that everybody is doing well and that your cardiac rehab programs are hopefully continuing to return to some sense of normalcy. We have a really important topic to discuss today and have some great panelists for you. The affinity group discussion we have today is going to be focused on supporting women that need cardiac rehabilitation. We've had quite a response to today's webinar, so we're really looking forward to a good discussion. Before we get started, I did have just a couple of updates related to the Take Heart initiative to cover. First, we've been making plans to resume training activities in May. This will be with a refresher training of our first two modules. It's been about a year since we last implemented those. We're combining those modules into a single refresher training, and then we'll start with new content beginning in June. For those who are maybe new to Take Heart or would like to know a little bit more about the trainings themselves, we ask that maybe you go ahead and visit the training tab on the Take Heart website. There's some additional information there. Second, if you're a Take Heart partner hospital, thank you. You have most likely recently been in a discussion with our team about restart activities, and we are near completing all of those discussions. If you haven't yet spoken to a member of our team, we ask that you please follow up with some available times to meet. We're using those calls for a couple of different purposes now that we are moving from what was originally one cohort, our first cohort and second cohort of hospitals, and combining them into a much larger cohort. We are using those calls to assign and reassign peer action groups so that you can be with hospitals that are most similar to your own. As the training and other partner hospital activities continue to move forward, also wanted to let folks on this call know that we'll be continuing with these affinity group discussions. We have been focused a little bit more on COVID-related topics in the past, but plan to, broaden that scope just a little bit and cover a wider variety of topics. Pretty much anything related to increasing cardiac rehab referral, enrollment, and participation more broadly. These are open to anyone, as they have been in the past, but we do encourage you to maybe take a look at the learning community page on the website and join that if it makes sense for you and your organization. With that, I'd like to go ahead and pass over the baton to Steve Hines, who will kick us off for today. Thank you.
All right, Cynthia, thank you very much and welcome to everyone. Just as a reminder, we haven't had an affinity group in a couple of months, but we're delighted to have you back. We're delighted to have 2020 over with and be into a new year. And today's event, like all events, these are forums where we want everyone to learn, everyone to share via the chat function, and everyone to be supportive of each other. And we're really gratified by when we see that happen in each event. Today's event, as Cynthia has said, is focused on how cardiac rehabilitation programs can best support women that are eligible and in need of cardiac rehab. And it's an important topic, and we're looking forward to it. It's a moderated conversation. We don't do presentations. We want to have a conversation. We want you all to be a part of that conversation as well. So the main participants in our conversation are Dr. Hisham Scali and the principal investigator of the Take Heart initiative, as well as Haley Stolp. And then we're also delighted to have Annie DeVelacsco and Jana Myrick with us as well. Two people that have fabulous things to say, and we're just delighted to have them on the call. As I've mentioned, we are going to have the opportunity to use the chat function. The thing that we want to stress here is that if you will set the field to all participants, that will enable everyone else in the audience to see your comments, and it will enable us to see the comments as well. And as we see those comments, we'll respond to them. Sometimes the speakers may respond to them as well. So make sure that you check the all participants box if you check attendees, we don't see those comments, and so we won't be able to respond to them. We're also going to be doing a few polling questions in a few minutes, and it's pretty straightforward how to poll. The questions will come up on the right-hand side, and then you'll just pick your answer, or in the case of today's questions, a couple of answers. We're interested in seeing your perceptions of how the cardiac programs are supporting women. So having said this, let me turn it over to Dr. Hisham Scali, and he can talk about the goals for today and take it from there.
Thank you, Steve. And thank you, everyone, for joining us today on this, I think, 10th or 11th Take Heart webinar here. We have over 100 people participating with us here, so that's really very exciting. I want to thank Haley Staub for joining us and helping me co-moderate this session, and our two wonderful participants who will tell us about their experiences in cardiac rehab, Miss Amy DeVelacsco and Miss Jenna Myrick, and we'll get there in a few minutes. I just want to, in terms of preamble, introduce the concept, actually, which is probably very familiar to many of you, that women in general are less likely to be referred, enrolled, and complete cardiac rehab participation, despite deriving at least as much benefit as their male counterparts. And I think this is a particular angle and perspective that we need to explore more. We need to understand why and how this is happening, with hopefully the prospect that we can improve this outcome and these numbers. Obviously, cardiac rehab programs are still coping with various aftermath effects of the COVID-19 pandemics. But I think if I take an example from our program, we are certainly on the upcoming curve of increasing our numbers and being able to help more and more patients. And so, from some of the polling that we have done with some of the programs that kindly answered our survey, what we have asked programs is that what is the activities that are specifically designed to support women, and the vast majority, we don't do anything different for women, but we'd like to do more. Some are doing some things to reach more women, but certainly can do more, and some, a smaller number, less than 5% or so, around 5%, have done some efforts to reach more women, and some have succeeded. So the goal from all this, as mentioned by Cynthia earlier, is really to share our experiences, learn from each other, and again, improve the field as a whole and see what strategies we can benefit from applying. So here, the focus of today's session is really go over again the data over how women are underrepresented in cardiac rehab, why are there fewer starting and fewer women completing, and what are the highest priorities that we can implement based on our discussions with our panelists. And hopefully also from discussions and input from all of you here, 120 participants, that you can put in our chat box and make this discussion even richer. And with that, I'd like to turn it to Haley Staub from the CDC and the Millions Heart Initiative, and tell us and go over some of the data and scientific evidence for our current statements.
Thank you, Hisham. I'm happy to be on today's event. I'm thrilled about this topic, delving into health equity, which is a big part of Take Heart as a whole, and seeing how we can improve uptake. So are women underrepresented in cardiac rehab? I think the answer is yes. That's why we're here today. Overall, women are less likely to be referred to cardiac rehab. They're less likely to enroll, and unfortunately less likely to complete the sessions. So this is a graph here from our recent analysis looking at Medicare beneficiaries that were eligible for cardiac rehab in 2016. And we see overall, so the dark green is the number of sessions, achieving the 36 sessions or more. The light green is the 25 to 4 sessions, and the yellow is the 1 to 24 sessions. And then the white, which unfortunately is the majority, is non-initiation of cardiac rehab. So, and these data are broken down by the race and ethnicity, and you see across the different sexes as well. So consistently, women have a lower participation in cardiac rehab across the board. Overall, for the Medicare, it was 18.9% of women participating in cardiac rehab, and for men, it's 28.8%. So a bit of a 10 percentage point decrease in cardiac rehab participation, which equates to about 9% less likely than men to participate in cardiac rehab and 13% less likely to complete cardiac rehab, which is really the goal here, as we know that there's a dose response for cardiac rehab. So the more sessions that are attended, the better the input. And 25 is what we consider that clinically meaningful threshold for participation. So we have a number of topics to explore on why we see these stances, but more importantly, what solutions are out there and what strategies we can help lift up. I'm thrilled to be introducing our panelists today. So we have two expert cardiac rehab graduates. These are very active women in the world of cardiac rehab and women with cardiac conditions. So Annie DeVelacsco is a very much proponent of cardiac rehab. She's been very vocal in her community. She's also a Women Heart graduate, and I'm happy to say she's a nurse. And with that, a recent cardiac rehab nurse. So she's got experience from both the clinical perspective and the patient's perspective. We also have Jana Myrick with us. Jana is a very vocal advocate in helping women speak to their heart conditions and being more sharing and open and developing a sense of support system for women to be outspoken about their conditions and what they need and ensuring they get that access. So with that, I'm actually going to pass it to Annie to speak a little bit about her experience in enrolling cardiac rehab and how that might align with the data I just overviewed. So Annie, I'll pass it to you.
Thank you. Thank you, Haley, Dr. Scully, and all of the people who have invited us to join today. It's certainly a privilege and a wonderful experience. Just briefly to let you know why I'm talking about this is that I joined a club I never wanted to be in about 20 years ago when at work I got some scary news about a health of a family member, and I immediately experienced Takotsubo syndrome or broken heart syndrome, where I ended up being rushed to the cardiac cath lab. When I got out, being a nurse, I said, okay, can I go home now? And they told me, no, you can't go home. You're having a heart attack. Frankly, that almost gave me a second heart attack, just hearing that. But from that point on, it was surprising to me that when I got discharged, in those days, I talk about it like the dinosaur days, but 20 years ago, I actually was in ICU and then in the hospital for a week following the heart attack. And even though I was a nurse, I was totally uninformed. It was totally unexpected. I was sure I was too young to have anything like this happen to me. So I left the hospital with absolutely no knowledge of what was I going to do, what was going to happen to me, and what lied ahead. So finding cardiac rehab totally changed my life. And I look forward to explaining ways that I think it could be available to other people, what I've learned over the years, how I changed my role from patient to cardiac rehab nurse to advocate, and now continuing in the role of a retired but totally involved individual. So thank you for the opportunity. My story is not that unusual. It happens every day, but I'm happy to share it.
Thank you very much, Annie, for this introduction, and it is our privilege to have you with us, and also an opportunity for us to thank you for your many years of promoting cardiac rehab. Do you want to tell us a bit about how and why it was hard for you to get or know about cardiac rehab or get into cardiac rehab in the beginning?
Actually, the physician never mentioned it to me, which I continue to see as a big problem. So nobody mentioned the idea of cardiac rehab. So even though they looked at me like, maybe you're a nurse, you ought to know, I had no idea because I wasn't working in cardiology at that time. Luckily, I have a friend that was, and I called her and she told me, girl, you need to go to cardiac rehab. Well, I had no idea what it was. So I called, I had a wonderful person, the director of cardiac rehab at that time, talk to me on the phone, tell me why it was so important. I had to go back to this cardiologist.
All right, and I think we have some of those answers. The top two reasons are logistical challenges related to family, work, or transportation that make participation difficult. But 62% of those who answered said checked that. And then the next one is B, lack of encouragement by cardiologists or cardiac surgeons to participate in cardiac rehab. And those are two very valid reasons, and that's what's been reported in a lot of the studies so far, is that the encouragement and strong reinforcement by the referring cardiologist or cardiac surgeon or the entire medical team advising the patient to enroll in cardiac rehab is probably what predicts a higher success rate of patients enrolling in cardiac rehab. And we can't do enough of that, of encouraging each other, whatever role we play in our organization, to continue to remind the referring physicians or nurse practitioners or physician assistants that reinforcing that idea with the patient that it is good for them, that they will derive significant benefit from participating in cardiac rehab. And then the other thing, which is more a systemic and structural issue, but the challenges related to family, work, and transportation, and that we have to also try to alter and improve as a society, and each of us in our own individual roles. So, Haley, do you think we could talk about about how starting cardiac rehab, what are the factors that are related to patients and which are related to clinician and health system factors?
Yeah, look forward to getting into that discussion. So the patient factors, again, those that impede the patient from being able to participate, or factors that are specifically relevant to them. That might be conflicting priorities, language or cultural barriers, and lack of social support is a big one. So we'll get into those items. And then on the clinician and health system side, again, the responsibility of ensuring that the women have the resources and tools they need to get into cardiac rehab. So Jana, maybe we'll start with you. What are the leading factors that you find make it harder for women to get into cardiac rehab?
I think the number one cause with the women that I talked to in my program, that they didn't have enough time off their jobs. I think that doctors need to keep women off a little bit longer where they can participate in the program. And then the family support, I can say, was probably the number two reason.
That's helpful. I remember, I believe it was you that had the concept of super women in their lives and thinking they can do everything. Do you care to elaborate on that?
Oh gosh, yes, we do think we are super women, that we think that we can maintain it all. That was one of my problems, where we will continue working, continue to do the things that we do because our family do come first, foremost, with most women that I know. And we have to put our bodies first. That was a big problem with me. We ignore the little signs that our body tells us, and we just keep going and going. And for my instant, it just stopped me dead in my track in the middle of the morning when I had my heart attack. And I'm thankful that my nurse that I called told me to go and get checked, because if not, I probably would have got up that morning and went right back to work thinking, okay, it's just indigestion. And when I got to the hospital, my blood work and stuff was coming back okay, but they kept me, and I'm thankful. I'm so thankful they kept me till up under observation, and it came back, I had a heart attack. So we have to slow it down and start listening more to our bodies and stop putting ourselves out there and thinking that we have to be the super women that we told we should be and support our families. And it's time for families to support us, and just trying to get women to see that now, that we do need the support, and we need the support of family, and we need support of doctors.
Yes, that's a powerful statement. And I welcome other comments in the chat and from our panelists as well on how we can help do that. How can we help women acknowledge when those messages are coming into their bodies and speak up and take action? I know that's very critical. I can speak from personal experience as well. My mother's not always the first to respond when she's got some health issues. Annie, do you have other comments to make on the patient factors that play?
Thank you, Haley. I echo everything that Jenna said is totally correct. But I'm going to think outside of the box a little bit. And I started trying to make an analogy that maybe everybody could relate to. Most of the time, you may be driving your car every day and not worrying about it. When your car breaks down, that's the time you begin to think that you need a new car. So I think it's so important to talk to the patient at the time of the event. That is when the patient is most vulnerable. That's when the patient needs to have some hope. And in our situation, what we found has worked over the years is having the use of what could be called like a patient ambassador. We have people who have been trained as Women Heart Champions who visit patients who have had a newly diagnosed event while they're in the hospital if they agree to the visit. And the cardiac rehab staff approaches them with that question, would you like to talk to somebody? And almost always they do. So when we talk to the patient, there's a huge barrier that is crossed when you can actually say to somebody, look at me, I had something similar, maybe even 20 years ago. It never ceases to leave my mind that the main thought that I had when I had a heart attack, even though the doctor told me I was going to be fine, I did not know anybody else at my age that had ever had a heart attack. My mother had died from one. So my frame of reference was bad. So seeing somebody else, especially another woman who had gone through this and could give me some longevity to look at, like when I visit a patient, I say, hi, you know, I was in a bed similar to this 20 years ago or 5 years ago or 2 weeks ago, whoever calls on them, that automatically gets their attention and enables you to communicate at a level that is so special and so different. So I think that if there's a way that the patient can be told about cardiac rehab and let them know that they would have other women they could talk to in their journey to get enrolled, and once they're enrolled, I think that that is a unique peer support that we could certainly take advantage of that would empower other survivors and has worked very well for us. We have had a support group going for our patients for 17 years every month. And those people in the group visit the people in cardiac rehab and occasionally in the hospital. So I would say that when you're fishing, you need to go where the fish are. So we've had good luck with the fish that we're using, and we continue to hope to have the same kind of luck.
Thank you, Annie. Those are very important points and well said. I wonder if you care to elaborate on those types of networking opportunities and specifically the Women Heart role in having a peer support network.
Okay, well, quickly, after I was in cardiac rehab for a while, they came out with a notice about a training symposium at the Mayo Clinic, which my director encouraged me to apply for. I was chosen and went with 60 other women in 2003 to a training symposium where we learned everything about heart disease, but more empowering and more important was all of a sudden I was in a room with women of all ages who were beginning the same journey with me. And that was so impactful and has continued that impact over the last 20 years for me. So I came back, we opened a support network for women called Women Heart of Miami. And then subsequently, we opened the only Spanish-speaking group, Women Heart of Miami in Espanol, a few years later. So we work closely with the cardiac rehab staff. When patients go to cardiac rehab, they get flyers and announcements about our meetings. We visit them. We call them. In the time of COVID, we didn't want to stop, so we've developed our Zoom call skills, which came through trial and error, but we have very successful Zoom call meetings with usually about 20 people. We still get notified of new patients. We call them, we invite them to the meeting, or we send them emails. So that's exactly what we did. And in our support groups, we alternate education and support. So we try to have guest speakers from the community and from our facility. And that is another good way to let the cardiologists know in our community the power of support and helps them to refer to us. So that's what's happened over the last 17 years.
Thank you, Annie. And I see in the comments also the mention of Mended Hearts, which has chapters throughout the country as well, another resource to help support women and potentially go into the hospitals at the bedside and help educate women about the opportunities for cardiac rehab. And ideally, as you shared, having a family member present in that process. Jana, do you have any comments to add on the need for social support or the role of spouses or offspring perhaps in that communication?
Yes, it's very important for your spouses and your kids to get involved with the program. I was fortunate that my daughter-in-law and son are doctors, but the remaining of my family did get involved with the care, and that was very helpful for me for the program. I don't think that I probably would have finished without the support that I received from them. I'm not that aware, I'm aware now of the other women groups that's out there to support, but during the process, I was not aware of any of these programs because none of them was offered to me about other women going through the process of this. So it's very important that you do have family and spouse that can support you, and I'm thankful for all of mine.
Thank you. And thanks again. Keep the chat going. It's really exciting to see all the different developments. I see Lauren Stable has an ambassador program. I know Lake Regional Health Center is one that's featured in the cardiac rehab change package. It's one of the last change ideas, so there's some resources there. Hisham, I wonder if I can bring you into as we move into the clinician and health system factors and your thoughts on how we can help mobilize the system as a whole to support women in the process.
Yes, thank you, Haley and Annie and Jana for your insights and experiences. And again, really, it shows the level of dedication from patients, but also from professionals, and how we really need to address multiple angles. And so the involvement of patients or past graduates, as well as someone like Annie, who's a nurse and working in this field, is very important. I read some of the chat comments and ones from Greg Merritt, well-known Greg Merritt. Hi, Greg, and how it is important to continue involving these graduates to encourage patients and who are hesitant, but also those who enroll and need to complete the program. From there have been quite a few studies looking at different health system factors, and some of them have been mentioned in the chat box, whether it's related to transportation or patients resuming work and so not being able to get into cardiac rehab. Some of the studies that were done is also the delay between someone having their index event, be it cardiac surgery, cardiac stenting, or heart attack, and what time they are referred and enroll and get their first session. And the longer the time between their index event and their first intake session, the less likely they would enroll and the less likely they would complete their cardiac rehab. So so getting that first visit as early as possible. Some patients might have a few days off after their heart attack or their stents, maybe 3-4 days, a week, 2 weeks. But after that, they get back to work, and so they can't get to their cardiac rehab right away. And often that's why they don't even get to that first session. But maybe if we were to get them right away when they still have those few days off into that first intake session, we might be able to, hook them and really get them to start, and then figure out ways of how to keep them into the program. Nowadays, in the last year or so, last couple of years, we are using more and more remote cardiac rehab delivery methods. And so maybe that's one way, if someone is low risk and healthy enough to get back to work, maybe by doing 2 or 3 or 4 sessions in person in a cardiac rehab facility, they can do the remainder of their sessions as a remote program, and with continuous check-in with the staff, so that we maintain that they're doing it appropriately and safely, and we can assess that they're doing better. by the end of the program. And so as a system, that's one of those are two things that I mentioned there, starting early and then thinking about alternative delivery methods for cardiac rehab. And then the other thing also as a system is, as Amy mentioned earlier, is really just increase awareness of the healthcare providers to make sure that cardiac rehab is offered to all eligible patients. I can tell you that when we talk about cardiac rehab in our system, whether it's during conferences for residents or grand rounds, or even just discussions with cardiac surgeons or physician's assistants in the cardiac surgery program, we often see a little uptick in the number of referrals after any of these interventions. So even as something as you could say, it's a small thing, I only talk to 10 residents in my hospital, and that could lead to actually an increase in the number of referrals that you'd see. You might need to do this every 6 months, every 3 months, once a year, whatever you can do, but getting that will increase your referrals until it gets more ingrained in the practice habits of the healthcare providers. Anything else you'd like to add, Haley?
I did want to bring in some research that a colleague of mine did, exploring the attitudes, beliefs, and perceptions of cardiac rehab in the enrollment process in Baltimore, specifically among African-American women between 35 and 64 years of age. And she captured some powerful quotes I want to bring into the conversation. So in asking the question, did your doctor refer you to cardiac rehab? The response, no, she's much too important for that. She's a transplant doctor, and so she's busy, and didn't really take the time. And another one, for me, it was not the transportation or the cost. I think the doctor just dropped the ball, and I wasn't informed enough or persuaded that I should really go, so I didn't. So again, speaks to the role of the clinician and those care extenders, those care coordinators, whoever that might be. And it might be from the hospital, and it might be from the program. It could be a community health worker. It could be support from Women Heart Associates or Mended Heart chapters. So I think that's a key take-home point there. Any other comments from a panelist before we move on?
Great. Thank you. So we have another polling question here. And really, we talked about starting cardiac rehab. This is relative to completing cardiac rehab for women. So please check, based on women in your community, what are the top 2 reasons women do not successfully complete cardiac rehab? The top 2 answers, so it's an incomplete response, but we had out of the 29 people, 18 answered as C, being the answer to logistical challenges related to family work or transportation prevent regular attendance. And then the next most common answer is A, perception that cardiac rehab isn't helpful or is something that can be done on one's own. And I think that's an important factor, as Amy said earlier, or we saw in the slides with her photo, is that cardiac rehab is not just about exercise. Most people think that it's just about exercise and I can do exercise on my own. But as you all know, is that it's not just about exercise, and it's the comprehensive multidisciplinary approach related to exercise, stress reduction, dietary counseling and advice, medication adherence and explanation, monitoring, smoking cessation, and so on. And all of these things together is what makes cardiac rehab such a successful intervention in improving outcomes for patients who participate. Someone in the chat box, David Meckimson, thanking Amy and the Women Heart Support in Miami for the incredible benefit there and impact on the female patients. Miriam Hospital, and thank you, Lauren, for being on, talking about their support group for women and how well it is attended, and also the advocacy that they're doing there. And again, C and A are the top 2 choices in terms of why women are unable to complete cardiac rehab. So logistical issues in terms of maintaining that once or twice a week regularity in coming to the program, and then the perception that rehab is not helpful and that it can be done on one's own. I think those are 2 things are really important and real barriers in helping women in completing their program. And these are things that we have to address at the individual and societal level. So, and with that, so what are some of the solutions that we could use to help women complete cardiac rehab? So, Haley, did you have, what are the suggestions you might have there?
Definitely seeing that education piece and making sure that it's effective and directly communicated. And I know videos can be one approach to doing that, but I opened it up to Jana and Annie from their experience talking with other women, both that are eligible for cardiac rehab and that have participated in cardiac rehab, as we move into the adherence and completion on what will keep them coming back and how they come back to the program, and ensure that that education is a mobilizer and that they remain incentivized and engaged in the process. So Jana, do you want to start us off on the issues that women are grappling with and how they can ensure and hopefully find some solutions to keep them coming back?
And getting them to come back, as Dr. Scully said, the program offers a lot more than just the exercise. The education is very important to the women. And I guess taking women who have, to me, been through it and understand it, and going in and talking to these women and helping them and encourage them to stay in the program, to get in the program, is very important to their health, because we all have a lot to live for. So that's the best advice I can give, because the program offers so many different offers to us, diet and everything from your lifestyle change. And getting these women to understand, just reaching out. And what is your opinion on it to me?
Thanks, Jana. I know you also shared previously about the concept of superwomen and the idea that women might have a sense of feeling guilty for perhaps taking time away for their families and or the expense, so the accumulation of co-payments. Any comments on that and how we can help support women in knowing to take this time for their health? And that can go to Annie or Jana.
Okay, this is Jana. I think probably developing a program for women may be helpful with the co-payment process. Some insurance do cover it though, but a lot of insurance don't cover it. So I would try to recommend trying to get some type of program that women will be able to afford the health care to go into the program.
And any other comments on how we can keep women engaged? And perhaps that looks like a gender-specific program, or at least a module or programs that are specific for women.
Well, I could speak to the slide where it says lessons learned as the cardiac rehab program nurse. I don't recommend everybody having a heart event to qualify for this. So with that unsaid, I can say that to me, and talking with my colleagues in cardiac rehab, there's so much to be said for the initial intake visit when the patient comes to cardiac rehab. In our facility, that's the time that there is a one-on-one opportunity for their program nurse to be having some interviewing time with the patient. And perhaps for many patients, that's the first time they ever have recounted what happened to them to anyone else, because they feel afraid or they have shame or other issues. So that is a really good time to get some rapport with the patient and just to forget that they are a patient, but just think that you are meeting somebody. And I think that there has to be a lot of cultural and cultural sensitivity, trying to figure out where the patient is coming from and be alert to those kind of things that will make them comfortable or non-comfortable, just as if you were engaging in any other relationship with an individual. So I think the intake is a very good time to really understand your patient, perhaps uncover some of their psychosocial or family issues. If the family attends, that's a good time to see the dynamics. Is the family member unengaged, or is the family member overbearing? Those are all of the kind of things that as a good nurse, you should be able to gather from that initial interview. And then I think it's your role to communicate that to the rest of the staff as you will not always be the one that's there with them when they have their sessions. So I can't overstress the importance of the initial interview, having it in a private place, finding out what the patient's cultural, family needs are, being sensitive to them and letting them know that you are there to listen to them and to help them. Now that's kind of funny because that can come forward in certain issues that when I asked my friends in cardiac rehab, my patient friends, what were the things that were off-putting to them? Nobody likes to have somebody ask you, what is your weight? So you have to shout it across the room. People don't like to have to put the leads on where they feel exposed and they can see them. I recall a patient that we have that was from another country who was very, very modest, and we had to actually take the patient in a different room. Once they knew we were willing to do that, they were very comfortable with the program. So I think that that's important. It's also, if you have identified anybody that's there at their session, another woman that could possibly be a good buddy, that seems to work out. They always like that. And there's a lot more accountability between patients than there are between staff and patients, as my experience in watching long-termers. Another patient will say, where were you the other day? Don't you know how important this is? That makes a lot more difference to them than one of us having to say that to them. I think it's very important to always monitor the gym so that there's very little negative comments going on, any kind of harassment, any kind of political agenda, anything that could help the patient, make the patient feel uncomfortable. I think it's the role of the cardiac rehab staff to nip that in the bud and to be alert for it, because the patient may not bring it up to you, but that could very well be a reason that they never come back. Again, reinforcing the fact that there are support group meetings, having people that have attended them actually talk to the patient, making sure the staff gives the flyers to the patient and encourages them to come. Involving the family is important, and always never forget that an encouraging word to a patient that's going through this from the professional is so important to them. And when they do their exit interviews, many patients will say, so-and-so kept me going because they always appreciated the hard work that I was doing. It's very scary to have to walk on a treadmill after you've had a heart event or lift a weight. You think you're not sure you're going to break. You don't know what's going to happen to you. So I think having an astute and compassionate cardiac rehab staff that communicates with each other can make a whole team to reinforce the patient continuing to come. The first visit is very important, and then maybe they will meet buddies to help them along the way.
Thank you, Annie. I'm seeing the chat and many mentioning reinforcing the need for that education, the social support. I know women are more likely to accompany their male spouses to cardiac rehab, and it's not the same vice versa. Many women show up to the program by themselves, so having that support system in place too, that's great. Wonderful. I really appreciate these comments coming in. Lots of great ideas. I think the idea of assessing the individual's needs is an important one too, Annie. Thanks for bringing that up. And some women might feel more comfortable for body image reasons, or sweating, or working out in the presence of men is not being comfortable. So excellent points. Jana, any other comments to wrap us up?
The only thing I can think of, I went to Emory St. Joseph, and they had a terrific program for the women and the men. It wasn't any body shaming or anything like that. It's just the support and just getting the women. You can have all the things that Ann just mentioned, but just getting the women to communicate with each other. That's the biggest ordeal, is communication with each other into the program. But other than that, I had an excellent program at Emory St. Joseph. They did all those things. It's just women have a hard time in speaking with each other about our issues and our health, and just getting them to open up about that and having someone there to communicate, because we went through the first initial interview, all the things that she mentioned, but it was still difficult for women to open up with each other. So we have to find a better way to communicate with each other about our health and to feel comfortable with each other.
Thank you, Jana. I love the idea of having that accountability system amongst the patients. So I see Greg's comment on, again, buddying up and doing a duo treatment plan and having that accountable approach. That's critical. Thank you. So real quickly, one strategy we didn't talk about was leveraging data. And I think having that performance report on how you're doing, not only for women in particular, but cardiac rehab referrals as a whole. So there are some tools in the change package that reports to using referral data from registries, perhaps using your own internal hospital data to assess participation enrollment, and ideally seeing those data by demographics, looking at sex and other factors and ensuring that you have an equitable approach for the cardiac rehab uptake. And that might be a huge driver, especially as those reports are shared with the clinicians in the hospitals to drive improvement. So look forward to having folks explore those tools. Again, here's another recap, and I think I'll pass it to Hisham for final comments. I want to thank again Annie and Jana for your discussions and for everyone in the chat. This has been a great conversation.
Thank you, Haley. And again, thank you, Anna, Annie, and Jana for your insights and counsels and advices, actually. And there's a lot of good ideas that we saw in the chat box and from your interventions. And indeed, you know, this is, again, one of the other aspects of every little bit helps. And so at every level, right, at the referral, the encouragement, at the intake, the explaining the program, during the program, the buddying up, or being cognizant and astute about people who are modest and how you can see them separately, or as they're doing at the Miriam of having a women's only class, for example. And so a lot of these ideas are actually will carry a long way if we apply them. And these are some relevant resources that we put together here. I'm sure there are many others, but these will be accessible on the Take Heart website, and you could explore them. And so I think we have a minute to answer a third question here very quickly about future topics that you'd like to see on these future affinity group sessions. There are 6 of them there. If you could pick 1 or 2, whichever you'd like to be seen, this will help address the comments, the topics that you'd like to see. And again, really thank you for a very enriching session again, both from the panelist sides and from the chat box. So really I want to thank everyone.
So I wanted to comment on the resources. Again, the change package, there are tools on how you can use data. There's tools on how to develop more flexible models to accommodate different schedules and address patient needs. I think also identifying those patients that are at risk for low engagement and identifying them ahead of time. So do encourage you to check out those resources. That includes tools from those that are joining us today. So thank you again.
All right, thanks very much. And if we go to the last slide, we'll just note that the next affinity group is likely to be in mid-May. So we'll be giving you more information about that. We do email the slides and an event summary out to everyone that's on the call, so you can look forward to getting that. And then at the end, you'll see a few pop-up questions. We do like to get feedback. We like to continuously improve what we do, as opposed to just, encouraging you to continuously improve in your programs. So turnabout is fair play. We welcome your suggestions, and please answer those feedback questions at the end. Thank you very much for your time. We are delighted for the input from all of you today. Thanks to our panelists, and have an excellent rest of your day and an excellent rest of your week.